Good morning. Basically, I want to thank the General Thoracic Club for the invitation, and it's my pleasure to present this topic on bariatric surgery and how it relates to reflux. So this is a broad topic, but I would like to associate reflux with obesity and somehow explain how bariatric addresses both reflux and obesity in this day and age. I have no disclosures. So if you look at this map here, internationally, there's a pretty good correlation between obesity and also reflux. In countries where obesity is prevalent, such as the United States or the UK, reflux is very prevalent also. In addition, in countries where obesity is not as prevalent, like India or China, reflux is not prevalent. So there's a very strong correlation between reflux and obesity. The prevalence of obesity and GERD has significantly increased over the last 30 years. And both conditions, when they're severe, can cause a tremendous cost to society and also healthcare. And in severe situations, as you can see, it may affect patient quality of life, also work, and may even lead to disorders of the esophagus like Barrett's esophagus and eventually cancer. This is essentially a graph showing that the BMI, as BMI increases, not only in the obese range, but the normal range, that your reflux symptoms also are severe. So in this manuscript that was published by Jacobson in 2006, you can see that in BMI of 30 and higher, there's a threefold increase in reflux symptoms. Also, in BMI less than 20, you can see also the reflux drop dramatically. So there's a linear relationship, not only in the obese range, but also in the normal weight range. The mechanism in obese patients may be a little bit different as opposed to non-obese patients. This is why bariatric surgery or Roux-en-Y or other operations may be a benefit here. It's not as if you were creating a valve like a Nissen. In obese patients, you have many mechanisms involved. One is the LES relaxation, secondary to obesity. Data suggests that the LES pressure may be variable in obese patients and actually may be higher because of the visceral adiposity. The angle of hits may be changed to a more obtuse angle that may affect reflux. 40% of patients and obese patients will have the hiatal hernia based on the literature. There is also ineffective clearance of esophagus by lack of saliva that's formed in obese patients and also impaired motility. The intra-abdominal pressure that is increased to visceral adiposity can lead to higher transdiaphragmatic gradient and may lead to hiatal hernia or reflux symptoms. And finally, there's a hormonal component to it. Visceral adipose makes hormones such as leptin, and these can be can lead to reflux of the esophagus. This is just actually a schematic that shows all these different factors involved. Again, LES may be normal or high in obese patients. Unlike lean patients with LES, low pressure is the main dominant force. Esophageal dysmotility, hiatal hernia is very prevalent in obesity. Transient relaxation and gastric or intragastric gradients are higher and leading to reflux symptoms. So the data in the literature suggested that because there are parallel rise in obesity in the last 30 years and reflux, there's some linkage there, certainly. Surgery is very effective, whether it's an anti-reflux surgery or obesity surgery. They're effective in both of these severe conditions, and the best surgical options is up to debate in obese patients, as is reflux for Nissen fundoplication, or do we do a Roux-en-Y or other option? And there's plenty of data out there in literature that supports that fundoplication in obese patients have a higher failure rate. So taking that all together, can we extrapolate that a bypass procedure may be better? And what bypass procedures are out there that may be a benefit? The standard care for treatment for GERD is crural repair, anti-reflux procedure, fundoplication, lengthening procedure as needed. But one is Roux-en-Y, a more attractive option in those patients, and we'll go over in that in a little bit detail now. So if you look at the literature, obesity does impact the outcomes after fundoplication. And many have published it, but here you can see that in obese patients, the symptomatic recurrence was markedly higher than non-obese patients in a paper published by Perez. Similarly, others have suggested higher failure rates for fundoplication in obese patients in terms of need for reoperation, symptomatic control, and lack of patient satisfaction. Now, what are the bariatric surgeries that are available out there for patients with reflux or obesity? And I would say that the malabsorptive procedures, such as duodenal switch or digital ileal bypass, are more of historical notice here. And they have been lost to favor because of too much weight loss and too much malabsorption. In contrast, the restrictive procedures like a laparoscopic band or sleeve gastrectomy have increased in numbers in the last 3 to 4 years. The gold standard is still the Roux-en-Y gastric bypass because not only it affects weight, it affects reflux by many mechanisms. And we have seen some data now that sleeve gastrectomy, although the increased incidence of the surgery in the last 3 years, is actually more refluxogenic. What are potential applications? And I'll talk about the 4 main applications of bariatric surgery or Roux-en-Y for GERD. And that could be divided up as an index operation for GERD in obese patients or morbidly obese patients. In the setting of failed prior anti-reflux operation, what's the data on that? And in terms of what we're seeing more and more now as the bariatric operations are increasing, specifically the restrictive type, we're seeing those patients will probably need recurrent surgery or redos because of intractable GERD. So the concept of Roux-en-Y, it's pretty straightforward and break it down to 3 factors. One, you're making a small pouch and eliminating the acid from the esophagus. The second part is diverting the bile from the esophagus. So these are immediate effects. So if you do a redo and do a Roux-en-Y, patient post-op day 1 will say, I have no heartburn. The later effect is due to weight loss. As the visceral adiposity decreases, the intra-abdominal pressure decreases, you'll see the sustained improvement in reflux over the next 2 months to a year. Micropouch is better. If you're going to do reflux with Roux-en-Y or bariatric, the reason why it's better because it is a lack of parietal cells in the cardia as opposed to the fundus. And also in this paper by Sapala, you can see that 1,000 patients had a leak rate pretty good, less than 1%, and they have a very low rate of reflux esophagitis. So that indicates the effectiveness of a small pouch when you manage patient reflux. So making an anastomosis of the cardia is favorable. There are inherent differences in the gastric cardia and the fundus, and some of the differences that we see and actually help in control reflux. The fundus over time tends to dilate, receptive relaxation. There's also quite a bit of parietal cells in the fundus. The cardia has an extra layer of oblique fibers. It doesn't distend over time like the fundus does. Also, there's a lack of parietal cells in the cardia. So again, it's much more durable in terms of not being able to stretch over time and also not making acid. So anatomically, the Roux-en-Y reconstruction, again, similar concepts I already mentioned on the slide. Small pouch, you can make a Roux-en-Y retrogastric, retrocolic, or anticolic, antigastric. You have to make a distal anastomosis to reconstruct for biliary drainage. But as you can see, the immediate effect of acid and bile diversion to the esophagus, patients don't have heartburn the next day after surgery. Now, this is not a new concept, and I put this slide up there because there's a lot of historically have championed this Roux-en-Y for bypass. In fact, Washer and Salo in England and also looked at comparison between Nissen versus Roux-en-Y, and in their follow-up of patients, the 21 in each arm in a randomized trial, the Roux-en-Y did far more superior in terms of reflux control. Salo, 1985, also published 7 patients who underwent a conversion from prior Nissen to Roux-en-Y, and those patients also had a very good to excellent response to reflux control. And at the same time, Dr. Ellis here in the States was also looking at some of the exciting data in Europe and published 36 patients who had a vagotomy and tracheotomy and Roux-en-Y diversion with excellent reflux control postoperatively. The Mayo experience, 10% of patients who had a redo fundoplication actually had a Roux-en-Y conversion. Majority had a redo Nissen, but subset of patients did have Roux-en-Y with good control of reflux. And then the effectiveness of reflux can be seen by Sendi's paper that the Barrett's regresses after Roux-en-Y bypass Roux-en-Y diversion. This is one of the earlier manuscripts came from UPMC. Jeroen Perry was a fellow there, and he looked at objective data after gastric bypass, And you can see that in intermediate follow-up, the GERD scores improved, resolved in the majority of patients, improved quality of life. So there were some data start to come out at the time when gastric bypass was getting popular that it was very effective to control heartburn. So morbidly obese patients with reflux based on the NIH guidelines, a BMI more than 35 with one comorbidity or BMI over 40 can be offered Roux-en-Y straight up front in that setting. And reflux is considered a comorbidity. Now, what about patients who are obese between BMI of 30 and 35? And I can tell you there's not much data to support that, whether you do a Nissen, whether you do a Roux-en-Y. However, Jones published his paper in 1998, and basically looking at 89 patients who underwent Roux-en-Y for intractable GERD over a 9-year period, and only one patient has symptomatic reflux post-op, and pretty decent weight loss. So there was some support that in patients with very severe GERD, that in the obese setting, Roux-en-Y may be also an option in that, but still, it has to be an individualized approach when you're talking about BMI between 30 and 35. So Roux-en-Y is an index operation. This is the first management of Roux-en-Y or gastric bypass, index operation for a patient BMI over 35. The reflux is intractable to medical therapy, and BMI in the obese range. If you have severe disease such as Barrett's or other comorbidities, you can offer them up front potentially, but select them very properly, and they have an individualized approach in that setting. The next topic we're going to talk about in the application of gastric bypass Roux-en-Y is failed fundoplication. And here, as you can see, you have multiple redos. A little paper published this paper that the more number of redos or operations you do, the complications increase dramatically. In addition, success rate drops dramatically. The first Nissen, 85% or higher. Third, less than 50%. So given that data, and then also understanding that the diminishing success of redos and higher mortality from esophagectomy in academic centers of high volume, up to 1 to 5%, and Roux-en-Y in the setting of obesity may be an attractive option in those patients in reoperative setting. So we published our experience in 2014 in Annals, actually looking at our patients in a retrospective review, as a prospective review. Basically, 100 patients or so over a 10-year period, UPMC. And the primary indication for Roux-en-Y in these patients in a reoperative setting was they had to have at least one prior anti-reflux operation. The complexity of the patients that you see is indicated by this slide here. 80% of patients were in the obese range. 2 prior operations, nearly 50%. Collis gastroplasty was performed in about a quarter of the patients, and a lot of them had esophageal dysmotility. It's a very complex set of patients with multiple prior operations to manage. And looking at the results, pre and post-op dysphagia score, ability to tolerate solids or liquids, as you can see, dropped significantly from pre-dysphagia to post-op. BMI dropped appropriately. None of the patients actually went below 20, so the weight was maintained. The GERD scores were in excellent range post-surgery. So again, emphasizing the effectiveness of Roux-en-Y in a reoperative setting. In addition, you can see that 80% of patients were satisfied, had excellent to satisfied results after redo from a prior Nissen to Roux-en-Y. And the GERD scores I mentioned, median score was 5. So in terms of reflux control, dysphagia, Roux-en-Y after it was converted from a prior Nissen, patient did quite well. Now, no matter how you look at it, no matter what series you look at in the last 10 to 15 years, the results have been duplicated. And the results have always been the same. No matter how complex the patients, prior surgeries, number of surgeries, 2 or more, 40%, 36, 48. No matter how severe the GERD preoperatively, the results post-surgery and after conversion for GERD, good satisfaction over 90%. BMI dropped significantly. Comorbidities resolved or improved in nearly all patients. Acceptable morbidity, 20 to 40%, and 0 mortality. So consistently, and no matter what series you look at, the comparison to other series, when you convert prior failed Nissen to Roux-en-Y, patients have done well. Others have also looked at here in 2012, Natal looked at fundoplication versus Roux-en-Y head-on-head comparison, and basically 94 patients had a redo fundo and 36 had a Roux-en-Y. Mean follow-up 20 months about, and no difference in age, gender, or BMI. And in follow-up those patients, they're concluded that the more complex patients in their group actually did better with Roux-en-Y. So 4 risk factors undergoing Roux-en-Y versus redo, patients did better with Roux-en-Y. Patient in a prior callus versus Roux-en-Y, actually patient in Roux-en-Y had less dysphagia and better reflux symptoms as opposed to the callus segment. Comparing Roux-en-Y to other reflux surgeries in this series, you can see that it was superior to redo fundoplication. Others also looked at callus versus Roux-en-Y, and in this paper, manuscript, 44 patients, 6-year period follow-up of recurrent hernia. 21 had a redo fundo, 23 had Roux-en-Y. Short esophagus is noted in about 16 patients, out of which 6 underwent callus and 10 underwent Roux-en-Y. And there was a high degree of satisfaction after Roux-en-Y patients as opposed to the patient who underwent a Nissen and callus in a reoperative setting. So this data, some suggest, although these are single institutions, these are case series, but still there's evidence that Roux-en-Y is more effective. So in terms of in a reoperative setting, in what situation would you favor Roux-en-Y as opposed to redo Nissen? And it's pretty clear in some of these patient factors. BMI, I would say 30 and higher, maybe. You would want to favor, lean towards Roux-en-Y. Primary GERD symptoms because of the effectiveness of Roux-en-Y to diverting acid and bile. Multiple prior operations because of the complexities of doing redo Nissen in those settings. Dysmotility of the esophagus. Delayed gastric emptying after redo Nissen. If you do another fundoplication, those patients have a lot of bloating symptoms, abdominal pain, and medical comorbidities. So if more of these factors are in the patient profile, the more likely you want to do a Roux-en-Y in a reoperative setting. Now this is a topic that I'm going to just finish on because I think this is also going to lead to probably more referrals to esophageal surgeons or surgeons who do reoperative surgery. And reflux after bariatric surgery, specifically focusing on the restrictive surgery. There has been a major shift in bariatric surgery in the last 3 to 5 years. The days of long limb diversion or jejunal bypass have gone. Lap band, although it was in favor in the early 2000s, have dropped out of favor because of the ineffectiveness for weight loss and also causing reflux symptoms. Roux-en-Y has kind of been stable, but it has dropped to some degree in the past 5-6 years. And the reason why it's dropped because of sleeve gastrectomy. And sleeve gastrectomy has increased from 17% to over 50%. And this operation is purely a restrictive operation. However, there's data coming out now in some of the randomized trial that the most common cause of reoperation of the sleeve gastrectomy is intractable GERD. So we have to kind of have a caution in terms of, it's certainly effective if on the weight loss, but you have to monitor this patient for reflux afterwards. So sleeve basically, just for schematic here, is you're removing probably about 2/3 of the stomach by firing a staple line across the greater curvature. As you can see, some of the mechanisms that may be in play for reflux after sleeve are distortion of the angle of His. Perhaps some of the sling fibers are resected doing dissection or stapling. And also, if you make the sleeve too narrow, you're going to leave an enlarged gastric pouch proximal to that, causing more acid reflux. So this is why a subset of patients' sleeve have intractable GERD and going to go into reoperative surgery. Some have recently looked at this in the last couple of years and published data. Here you can see Mandeville in 2017, in a follow-up 8.5 years, in a patient with sleeve gastrectomy. Over nearly 50% of patients had de novo reflux. So these are patients who did not have reflux before sleeve actually end up having reflux after, and 50% of patients experience reflux symptoms after sleeve gastrectomy. So this is concerning. And then some of those patients, in their experience, underwent reoperative surgery and had a gastric bypass because of intractability of GERD. At the least, these patients should be followed with endoscopy or clinical surveillance for reflux and other issues after surgery. Here you can see also the in 17% of patients in this experience by Jenko in 2017, patient developed Barrett's esophagus after sleeve gastrectomy. So certainly there is a predilection for reflux, Barrett's, maybe even adenocarcinoma. This is a trial that is recently published in 2018 in JAMA. It's a prospective randomized trial looking at essentially two groups in 4 centers in Switzerland, evaluating laparoscopic sleeve gastrectomy versus bypass. And the end results, they were looking at the endpoints of weight loss and comorbidities. The groups are pretty evenly enrolled in over 100 in each arm with a 5-year follow-up. And you can see here, the data is pretty striking. Although the weight loss is pretty similar in both groups, at least in 5 years, but the reflux is far worse after sleeve gastrectomy in terms of initial reflux, in terms of worsening reflux after sleeve gastrectomy, in terms of de novo reflux. So these patients, again, sleeve gastrectomy is not an operation that we would propose for a patient with severe reflux symptoms or obese. And in this series, 9 out of the 100 patients or so were converted to Roux-en-Y after failure of sleeve due to intractability of GERD symptoms. Similar morphology here. This operation is abandoned in the States because of inadequate weight loss, because of stomal stenosis leading to intractable GERD symptoms. The vertical banded gastroplasty, a subset of patients. These patients also will need surgical revision. Gainier published in 2010. Pre-op BMI 42, inadequate weight loss after VBG. GERD symptoms are very severe, dysphagia and over 50%. Post-surgery with a good morbidity and mortality, appropriate drop in BMI after Roux-en-Y conversion, and remarkably, the reflux improved and dysphagia right away after surgery in terms of dysphagia control, GERD control, and also improvement in comorbidities. So in this subset of patients, you will also have to do a revision to Roux-en-Y. So this is a broad scope of managing reflux, whether it's index operation, whether it's reoperative surgery. So in conclusion, the data suggests that after the mechanism causing reflux and obesity are maybe different. And for that reason, gastric bypass and Roux-en-Y may be more attractive in those patients because that addresses many factors. Roux-en-Y can be offered initially to patients with BMI of 35 with a hiatal hernia and intractable reflux, and is also could be considered in patient in reoperative setting when prior fundoplications fail. Roux-en-Y is an option in the management of intractable GERD in patients who have restrictive bariatric operations, and we're going to see more and more of these patients in the next upcoming 5 to 10 years. And when considering Roux-en-Y for intractable GERD, I think at this time you still have to have an individualized approach. This is not an operation that, like a Nissen, can be reversed potentially. So there's long-term follow-up of the patient. So you have to still have a more of an individualized approach in the centers of high volume and excellence. Thank you very much.